Bismillahirrahmanirrahim. Executive Council of PSNM, my teachers, colleagues, students, ladies and gentlemen, Assalamu alaikum and very good morning. Thank you very much, Dr. Saad, for the introduction. There is a bit correction. Nowadays, I am not in Noori, I am working at Sinam, which is one of the oldest center of the PAEC in Lahore. The rest is a bit fine except one or two things. Anyway, with this, as I have been given the time of 15 minutes for a presentation which is, I think, very difficult to complete, and especially after a presenter who was, after a very good presentation, it was difficult to cope up with the things. Anyway, I'll try to finish it in the time, and if I can give something for the students and the practicing physicians. So the topic, as being told, is iodine 131 therapy in differentiated thyroid cancer, optimizing imaging and therapy. And you all know that optimization means in medical field that a diagnostic imaging that is being done in a way keeping the safety of the patient in mind, as well as the information which we can get from the patient for that particular disease. And this concept of optimization or bringing things is very important in whole the medical field for any treatment or for any disease management. And to begin with, I want to quote a hadith from Prophet Muhammad Sallallahu Alaihi Wasallam regarding the treatment, that for every disease there is a cure, and when that added to the management, the patient gets healed by the will of Almighty Allah. And this is the basis of all treatments which we learn in our medical school. Regarding the topic, as we all know that the treatment of DTC, it starts with the surgery, followed by the radioactive iodine treatment, and that the risk stratification and the categories which have been assigned to the patient. So I will not go into the details what are these risk stratifications, but these terms will be used during the presentation. And I'll keep focus on the imagings which are related to the iodine 131 therapy before the therapy, after therapy, and the surveillance. So the risk stratification, you know, there are intermediate, low, and high risk. Okay, the radioactive iodine is given with the intent of ablation to destroy the benign remnant thyroid tissue, that is followed total or near total thyroidectomy. It may be given in an adjuvant setting for the suspected not identified remaining thyroid cancer following the surgery, or in therapeutic intent in the cases in which it is already being known that the patient is high risk or having that metastatic disease. The ATA guidelines which are being followed in most our centers also tells us about the stratification and the things for which this treatment is given. That in low risk groups, there is typically radioactive iodine is not recommended. However, if it is being given in certain conditional circumstances, it is given in the low dose, and the intent is to either none or for the remnant ablation. There are many definitions behind this, and we will give just a summary of these treatments. In case of the intermediate to low or low to intermediate to high group, we can consider in some cases the radioactive iodine treatment, but in the medium range dose, and that is for the remnant ablation or sometime for the adjuvant therapy. Whereas in high risk group, of course, this radioactive iodine treatment is recommended in a high dose with the remnant ablation and adjuvant therapy, whereas in the metastasis, this is being given with treatment of known disease as well as for the remnant ablation. Before the radioactive iodine treatment, we need to know the size of the remnant thyroid tissue if it is present, or if there is any other disease in addition to the remnant thyroid tissue like lymph nodes in the neck and other things. In our practice, in our setup, most of the centers, as you all know, that initially this thyroid cancer, differentiated serious thyroid, is being treated by our radiation oncologist colleagues, and that's why the usual practice was that surgery was being done followed by the radioactive iodine therapy, and as I remember, there was no assessment of the residual thyroid tissue or whatever it is. And in most of the patients, we get that we have to give 2 or 3 times the ablation dose to ablate the remnant thyroid tissue. Because of the surgery, in the notes it was being written that it is total or near total thyroidectomy, whereas the patient has got a significant amount of the residual thyroid tissue. So at that time, as the supply of the radioactive iodine as well as the concept of stunning, we used to do the plain technetium thyroid scan to assess the residual thyroid tissue. And many of the times we have to refer back the patient for the redo surgery. And with the passage of time, when we have developed this liaison with the surgeon and all the things, now the number of the patients who are to be sent to the surgeons, especially who have diagnosed before the surgery for the redo surgery, are very less. So however, the ATA guidelines, they recommend the pre-therapy scan in some conditional cases. The recommendation is that the diagnostic scan may be considered for patients that are undergoing radioactive iodine treatment prior to their therapeutic ablation. And this scan is particularly important when higher doses are being administered to the patient, especially in the grade 4, to define the MTA dose for that patient. So what are the advantages or what we get from this pre-therapy scan? The changes which we can get from this scan are, we can detect the large thyroid remnants if they are present, as I was talking about that. Then detection of an insignificant remnant, which when combined with a TG level of less than 1 nanogram ml, may obviate the need of the radioactive iodine therapy. And same, we can detect the clinically unsuspected nodal or distant metastatic disease, which findings may alter the decision of radioactive iodine therapy. This concept of the pre-therapy scan, this has been supported by many studies in the literature, in which it has been concluded in different studies that this scan may downstage or upstage the patients of the DTC before the radioactive iodine therapy. And in a meta-analysis, the percentage which in which the stage have been changed with the pre-therapy scan was between 29 to 57%. Therefore, this scan is recommended in conditions where it is required. The scan alone cannot determine the stage of the disease, but as this talk is limited to the imaging, I will focus on that. Then we come after the treatment, the post-therapy scan. Of course, we are doing post-therapy scan, and that is very important. And the advantage, the one main advantage is that when we give the larger doses, we can assess the disease if it is present there or not. The concept of this information, which can alter the treatment, especially the decision about the radioactive iodine scan, this is being supported by different studies in which they have found that about 6.3% of the functional metastases, they are found on the post-therapy scan, whereas in another studies, 13% of the patients, the disease was found which was not initially present in the pre-therapy scan. Therefore, it is recommended that the post-therapy scan should be performed. But in addition to the planar imaging, which is being routinely done, the SPECT-CT has an importance for this post-therapy scan, and for that the ATA also has a recommendation for which that this SPECT-CT should be performed. This will, the patients will get benefit in a way that some lesions which are being difficult to be labeled as benign or being the malignant, that can be identified on these scans, as well as the number of the lesions can be increased, and it has an incremental value in the diagnosis and the further planning of these patients. However, its availability and time and cost, in some cases we cannot do it in the routine. However, when it is available, it should be performed, and it will add to the further decision planning and the further management of the patient. Once this treatment has been given to the patients, then subsequent follow-up. For who are the patients on which this subsequent whole body scan should be carried out or not. So the optimization means that if a diagnostic test is not required, that should not be done, especially if it is related to the radiation. So subsequent whole body scan is indicated primarily in 3 clinical settings. Number one, for the patients with abnormal uptake outside the thyroid bed on post-therapy whole body scan. And number two, for the patients whose post-ablation whole body scan is of limited use because large thyroid remnants were present and the lower uptake in the neck lymph nodes may be present over there. And also for the patients in which there is a rising TG or elevated TG antibody levels, and when neck ultrasound does not show any suspicious finding, so in post subsequent whole body scan is carried out like after 6 months to 1 year. Then we come to the surveillance, because once the treatment is completed, then this during the surveillance, the patient who have undergone lobectomy or total thyroidectomy without radioactive iodine, that when we characterize risk stratification, we found that this patient does not require the radioactive iodine treatment. In those cases, radioactive iodine scan should not be performed in the surveillance as well. Patient with DTC having low or low to intermediate risk of recurrence and who have excellent response to therapy, they do not require this whole body scan. But however, the patients with the DTC who are intermediate to high or high risk groups, that can be evaluated with diagnostic whole body scan to evaluate the iodine AV disease. And SPECT CT is preferred in cases as we have talked earlier. Then the PET CT role in cases of the DTC is iodine 124 PET is good, and it has some value, and some studies have shown that it adds more information as compared to the planar imaging. But there is I could not find any study who has compared the SPECT CT with the iodine 124 PET. However, there are papers available which can, it's found that more than about 49% cases we can improve the accuracy with the help of the PET. Then comes the cases of the occult thyroid carcinoma, that is the patients in which the cancer, after the treatment we cannot find out the remnant tissue with the help of the conventional imaging, that is whole body scan, but there are other parameters who are indicating that the disease is present. So in those cases, the empirical dose of radioactive iodine is being given, and with that we can have the scan, or we can evaluate the iodine avidity with the whole body scan if we can do that. However, in other cases, we can do the F18 FDG PET, and there is a clear-cut recommendation for that. And it is employed as a prognostic tool in patients who are at highest risk for possible disease progression, and also for the evaluation of the post-treatment response following systemic or local therapy like radiation, etc. There are certain other agents in addition to the F18 which are being used nowadays for this imaging of DTC in cases in which disease is not being detected by conventional imaging, but these agents are not being established so far. However, the studies have some promising results. So at the end, we can summarize that the pre-therapy, that is before radioactive iodine treatment, imaging is necessary to see the residual thyroid tissue and neck lymph node status. Post-therapy scans are recommended and may add additional information, and for that matter, SPECT CT, if available, must be performed in selected cases. In occult thyroid cancer, the F18 FDG PET CT is used. Other PET CT imaging agents are in investigational phase. Thank you very much for patient listening.